Hello and good morning, ladies and gentlemen, esteemed guests and valued members of our community. Thank you for giving me your attention. I am Dr. Alicia Willey. I am Director of Refugee Women's Health at Valleywise Health, also co-director of the Women's Global Fellowship at Creighton University, and obstetrics and gynecology faculty here at Valleywise Health. Today, I want to talk about the crucial aspect of our healthcare system that often goes overlooked: the building of trust. Trust is foundation upon which any effective healthcare system is built. It's the bridge that connects healthcare providers and the diverse communities that they serve. Without trust, the system falters and individuals may not seek the care they need, leading to detrimental outcomes for both individuals and public health as a whole. I have no financial disclosures to discuss, and my practice is focused primarily on obstetrics and gynecology in refugee health. Therefore, this talk focuses primarily on these niche groups, yet culturally appropriate care is translatable to men, women, and pediatrics. Moreover, to refugees, immigrants, migrant workers, and other American minority groups, including those with limited English proficiency. I myself am not a minority group and was born in the United States, yet I have elicited feedback from my cultural health navigators and colleagues to make sure that the information divulged here is as accurate as possible. This talk focuses on refugees' health and inequity, which is partially from the trauma and life experiences that these communities have persevered. Although there are no graphic images used in my talk, I apologize if any of the topics are found to be offensive. By the end of this talk, the audience will be able to list ways in which cultural health navigators promote the health of patients in comparison to that of using traditional language interpreters. Also, they will understand a brief background of the global refugee crisis, the history of refugee acceptance into America, and who our refugees in Arizona are. They will also understand health equity versus health equality and how this goal is appropriate for vulnerable populations. They will understand some of the specific refugee screening tools that we have available and how cultural health navigators have made an impact in our community and many of the resources available both locally and nationally to help serve this community. Here's the outline. I also, discussing this topic, would like to take a moment to remember the catastrophic natural disasters that happened earlier this week, including the earthquake in Morocco and the flooding and dams that flooded in Libya, with over 10,000 still missing. And I will again address this later in the talk. One in every 110 people on Earth have been forced to flee their homes. In the world, one person is forcibly displaced every 2 seconds as a result of conflict or persecution or natural disaster. Who are the refugees? The Refugee Act of 1980, Congress identified the United States' historic policy of aiding individuals fleeing persecution from their homelands. And a refugee is primarily defined in the Immigration and Nationality Act as any person who is outside of any country of their nationality because of persecution or a well-founded fear of persecution on account of race, religion, nationality, membership in a particular social group, or political opinion. We are now witnessing the highest level of displacement on record globally. An unprecedented 108 million people around the world have been forced to flee their homes. Among them, there are nearly 35 million refugees, over half of whom are under the age of 18. There are also an estimated 4.4 million stateless people who have been denied nationality and access to basic rights such as education, healthcare, employment, and freedom of movement. To note, not all forcibly displaced persons are refugees. Other notable groups include internally displaced persons, people who have been forced from their home but have never crossed an international border, usually from internal strife of their country or natural disasters, such as the people in Morocco and Libya earlier this week. Internally displaced persons are not protected from the same international laws nor eligible for the same aid as they are under the care of their own government, which is, if there is significant internal strife, the government may not be able to give them aid. The countries that have the highest number of internally displaced persons are Colombia, Syria, Democratic Republic of Congo, and Yemen. There are also asylum seekers. An asylum seeker is a person who has left their country and is seeking protection from persecution and serious human rights violations in another country, but who has not yet been legally recognized as a refugee and is awaiting to receive a decision on their asylum claim. Seeking an asylum is a human right, and this means that everyone should be allowed to enter another country to seek asylum. And there are currently 2.9 million asylum claims worldwide. Other groups that one may have heard of include migrants, yet there is no internationally accepted legal definition of a migrant at this time. To come to the United States, refugees must first flee their country of origin to country of asylum. Sometimes these are neighboring countries, but also sometimes refugees must cross multiple borders before finding a refugee camp that will grant them access. There are many reports and publications about the refugee migrations, and Amnesty International estimates 56,771 people have died during migration, and this does not include illness, injury, and gender-based violence, including rape that these refugees suffer in seeking asylum. There have been 2.6 million new claims in the past year, the greatest of which are applying to relocate here in the United States. And 52% of these people are originating from just 3 countries: Syrian Arab Republic, Ukraine, and Afghanistan. So far, there has been successful resettlement of 114,300 refugees. Over the last 50 years, there have been different trends in the communities seeking asylum. As you can see, there's a great increase over the past few years, and the UNHRC estimates that this sharp rise of refugees seeking resettlement is due partially to the humanitarian impacts of the COVID-19 pandemic, leading to the protracted refugee situations in camps, and in addition, the Ukrainian crisis and continued movement of people out of countries such as Afghanistan and Venezuela. The United States is currently at historic lows for refugee resettlement. The resettlement ceiling was decreased to 30,000 in 2019, but recently the Biden administration has increased the ceiling to 125,000. In 2021, 13,700 refugees were resettled, and the following year in 2022, they doubled this number with 29,000 refugees resettled. Although each of the 50 states has resettled refugees in the past, Arizona is noted to be among the top 10 of states accepting refugees. Once refugees arrive in the United States, there are many services that they are offered. In terms of state and federal benefits, refugees are eligible for refugee cash assistance and refugee medical assistance. They are offered these services within the first 30 to 90 days after arrival, and they receive a case manager and assistance securing employment. Typically, refugees stay connected with their case manager for 6 months to a year as they are becoming oriented. They receive apartment rentals, basic furnishings, food, clothing, and as well as health follow-up, English classes, and job or school placement as appropriate. My predecessor, Dr. Krista Johnson-Abaku, had looked at the refugee experience with relocation to the United States and introduction into the Western medical system. She performed the largest study to date on Somali refugees, incorporating a mixed method community-based research study involving 515 surveys, 18 in-depth individual interviews, and 5 focus groups on Somali women. Preliminary data unearthed the underlying perceptions of the refugees on their healthcare here in the Western medical system. They had negative experiences in healthcare involving their sociocultural context, their traditional held medical beliefs, prior negative experiences in the healthcare system, which then contributed to their fear and mistrust of Western medicine, feelings of misunderstanding and stigmatization, especially towards cultural practices such as female genital cutting, and overall disempowerment and discrimination. As a result, especially in obstetrical care, Somali women intentionally presented late for prenatal care, would delay going into the hospital while in labor, refused many medical interventions, or simply did not participate in medical care. The social determinants of health have a major impact on a people's health, well-being, and quality of life, including access to quality education, having safe housing and transportation in their neighborhoods, living in an area free of racism, discrimination, and violence, having access to job opportunities and income, access to nutritious foods and physical activity opportunities, being able to live in an area without polluted air and water, and having access to education for language and literacy skills. The social determinants of health have also been viewed in the policy rainbow created by Dahlgren and Whitehead in 1990, describing the layers of influence of an individual's potential for health, both their core non-modifiable factors, seen here in red, such as age, sex, and genetic factors, but also the modifiable factors expressed as a series of layers of influence, including a personal lifestyle, physical and social environment, and wider socioeconomic, cultural, and environmental condition. The model has been useful in providing a framework for raising questions about the size of the contribution of each of the layers to health, the feasibility of changing specific factors, and the complementary action that would be required to influence linked factors in other layers. In countries where civil war and unrest breaks out, people's health may degenerate quite rapidly due to the general socioeconomic and environmental conditions, because factors such as the availability of food, shelter, and drinking water will become dominant in predicting someone's health. Healthy People 2020 defines health equity as the attainment of the highest level of health for all people. To achieve health equity, we must eliminate avoidable health inequities and health disparities, requiring short and long-term actions. Here we can see an image to compare health equity and health equality. The WHO states reducing health inequities is important because health is a fundamental human right, and its progressive realization will eliminate inequalities that result from differences in health status, such as disease or disability, and the opportunity to enjoy life and pursue one's life plans. Health inequities also imply differences in the presence of disease, healthcare outcomes, or access to care between populations with different race, ethnic, gender, sexual orientation, socioeconomic status, language barriers, and geographic location. Thus, to be effective and sustainable, interventions that aim to reduce health inequities must go beyond remedying particular health inequality, but must also empower vulnerable populations through systemic changes in such areas as health policy, law reform, or economic or social relationships. Across the country, people in some racial and ethnic minority groups experience higher rates of poor health and disease for a range of health conditions, including diabetes, hypertension, obesity, asthma, heart disease, cancer, preterm birth, and other conditions compared to their white counterparts. Added to this, the burden of trauma, torture, and violence that the refugee community has experienced has a considerable effect on their mental health and decreases their overall wellness and ability to succeed. Communities can prevent health disparities when community and faith-based organizations, employers and healthcare systems, public health agencies, and policymakers work together to develop policies and programs and systems based on the health equity framework and community needs. This talk is going to expand upon at-risk populations, such as specifically refugees, for whom health equity is an essential human right, but also focusing on how language and culture create a foundation of trust, which is paramount for attaining health goals in these marginalized communities. One powerful tool we have at our disposal is to build and strengthen trust in the healthcare system with the concept of cultural health navigators. These navigators are individuals who possess a deep understanding of the cultural norms, values, and languages of the communities they serve. They are community members themselves, often from backgrounds that have historically faced disparities in healthcare access and outcomes. Let me share with you some compelling reasons why utilizing cultural health navigators can make a transformative impact in our patients' health care. In 2006, the community health worker or cultural health navigator was defined as a frontline public health worker who is a trusted member of or has an unusually close understanding of the community they serve. This trusting relationship enables the community health worker or cultural health navigator to serve as a liaison or intermediary between the health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. A cultural health navigator also builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. Our cultural health navigators are able to establish a foundation of trust for each healthcare visit. Most cultural health navigators working in my clinic have been present for over 10 years and therefore have developed a significant relationship with each of the patients. They understand their past medical history and can provide details on the patient's prior workups, treatments, and concerns that the patients may have expressed before, but might not feel comfortable in acknowledging during the present visit. In many cases, the patients will not feel comfortable discussing health issues unless they have a cultural health navigator present who they trust, even if their English has now become proficient during their time in the United States. In my practice, when a patient is delivering via cesarean section, they have the option to bring one family member with them into surgery. Once a patient elected to bring their cultural health navigator to help hold their hand through surgery and meet their brand new baby because they felt that this would create the safest environment for their delivery. In our refugee women's health clinic, we are also able to give gender concordant cultural health navigator care. This is something that is not always possible when calling into a phone interpretive service. And often there are male interpreters that may be a barrier to eliciting sensitive topics from patients, such as sexual history, gynecologic issues, and menstrual cycles. Also, given the small size of these communities, calling an online interpretive service may actually be contacting the patient's cousin, nephew, or uncle, which would also create significant barrier and decrease trust. The cultural health navigators are also able to help with structural barriers to accessing healthcare. Even for those of us that English is the first language, it can be trouble to navigate through some of the phone trees to access a live person for scheduling or follow-up care. The cultural health navigators schedule their patients' appointments, communicate with them directly via WhatsApp to remind them of appointments, and call and arrange for taxi services to and from appointments. This has led to a significant increase in number of patients who are arriving to each of their appointments. The cultural health navigators also provide language services on printed materials, as most printed materials in the healthcare setting are either in English or Spanish. But for a patient who is speaking only in Arabic, they might not be able to read any of the materials. But also, the cultural health navigators will pick up their prescriptions from pharmacy and again inscribe the instructions on the bottle. They will help walk the patients to the laboratory to check in for their appointment or bring them to imaging services. Our cultural health navigators are present on campus most days of the week and will arrange for their patients to be present on days that they are available to assist with this care. We have found many improvements in patient outcomes with the use of cultural health navigators. A study was conducted to assess the patient's understanding and level of knowledge of the resources available, outreach to provide education and disseminate information, and the quality of care that the providers were training for these patients. Reassuringly, the refugee women who completed the study reported mostly positive experience with care, including knowing how to get care, feeling confident in their ability to advocate for themselves, and feeling of being treated with dignity and respect, feeling comfortable discussing their female genital cutting or other sensitive topics with their provider. Furthermore, we looked at the rate that patients were picking up their prescriptions after discharge from the hospital. In these healthcare situations, a phone interpreter alone was used, and a statistically significantly less number of patients were picking up their prescriptions as prescribed. Yet, in the clinical setting, with the assistance from the cultural health navigators, the patients were picking up their medications equal to or greater than their English-speaking colleagues. The Refugee Women's Health Clinic here at Valleywise was founded in 2008. Our patients hail from 59 countries across sub-Saharan Africa, Southeast Asia, and the Middle East, as well as 45 languages spoken by our patients. We have 18 languages spoken by live, full-time trained cultural health navigators, and we have served over 6,000 patients and have delivered over 1,400 babies since the creation of the clinic. Some of the largest populations served are from Somalia, Burma, Iraq, and the Democratic Republic of Congo. Our mission is to provide culturally grounded and linguistically appropriate healthcare services to the growing refugee and immigrant communities in the Phoenix metropolitan area while seeking to reduce and eliminate health disparities and cultural barriers of care. The long-standing infrastructure of community partnership, engagement, and shared community leadership exists through the Refugee Women's Health Community Advisory Coalition here in Phoenix, which remains at the very core and foundation of the Refugee Women's Health Clinic operations. The Community Advisory Coalition is comprised of an interdisciplinary team of more than 60 stakeholders from various community organizations, representing local ethnic organizations, refugee resettlement, voluntary agencies, mental health and social service agencies, as well as academic partnerships who serve in the community outreach and engagement activities of the Refugee Women's Health Clinic, informing the initiatives as well as facilitating coordination of culturally competent care, service, and support. Community engagement is key in creating trust. This is when the cultural health navigators are reaching out into the community directly, reaching out and engaging multiple stakeholders, including men, youth, elders, and religious leaders. When the only engagement that we have is our single patient, even if we are able to instruct the patient and educate them on the COVID-19 vaccine, if they come home and none of the rest of their community understand or have bought into the idea of vaccination, there's likely to be low vaccine uptake. So during the COVID-19 crisis, the community health navigators reached out to the community and had many sessions for bidirectional learning and to build trust to be able to increase the vaccination in our communities. Other groups that are useful in these communications are reaching out to the ethnic community-based organizations, social service agencies, and school and law enforcement. In this way, we're able to have economic empowerment, gender equity building within these communities, as well as decreasing intimate partner violence and stigma reduction. We do have several refugee-specific assessment tools that are available for these patients. There are many issues and setbacks that a refugee may have when they first come to America. One can be literacy issues and lack of prior schooling. As part of our intake assessment, we ask every patient what their schooling level was in their home country and in their country of asylum. We also ask about history of screening for each patient, as well as history of health issues and treatments that they had received either in their homeland or in country of asylum. Many patients have to take time to learn the new laws here in America and about family and child welfare as it is here in the United States. But they also learn the customs and norms and rights that they can exercise here in deciding their healthcare plans and goals. Discussing obedience versus acquired learned rights, as many other countries have a paternalistic view on healthcare, and patients would not have options in choosing different therapies for their treatment. Refugees are also very at risk for predatory behaviors as they do not understand how to navigate either the healthcare system and so having these cultural health navigators being able to put the healthcare services into their cultural context allows them to build their ability to make decisions for themselves and avoid areas of vulnerability. There's also pre- and post-war issues for our refugee community. Many have been tortured, had trauma, or gender-based violence that has a significant impact on their long-term physical and psychological health. The CDC does also have a list of tools available to make sure that a refugee is receiving a complete medical screening upon arrival. But you will notice here that there is also that section on mental health, which with their history of trauma and violence, I would argue is one of the most important to making sure that the patient is able to meet their healthcare goals. The Refugee Health Screening 15 is a newly validated mental health screening tool developed by the Pathways to Wellness. It is a culturally competent and short screening tool that detects symptoms of anxiety, depression, and post-traumatic stress disease in refugee populations from a variety of countries. It has been field tested in community health settings and requires limited staff training and adds less than 10 minutes to each patient's visit. The tool has been validated in English and many other languages, including Arabic, Burmese, Karen, Nepali, Somali, Swahili, Kinyarwanda, and more. These are fundamental languages of the patients seen at the Refugee Women's Health Clinic. And when a patient is first presenting for care in our clinic, and a RHS 15 screening tool will be given to the appropriate cultural health navigator that interprets for that patient. And the cultural health navigator provides live interpretation of the screening tool's questions to patients that wish not to self-administer. Individuals that cannot speak or read the above languages are not screened, and each patient is screened only once at the beginning. If they have a positive screen, then they receive a referral to the Jewish Family and Children Health Services or the on-site social health worker who also facilitates this referral. The implementation of the RHS 15 tool in an outpatient clinic highlights the sustainability of evidence-based practice change. And there was a significant relationship between the ethnicity and positive and negative scores of the RHS 15 in our patient population, and a significant relationship between primary language and positive or negative score. 29% of the women screened were Burmese and had a very low percentage of positive screens, while 26% of those screened were Iraqi and had a high percentage of positive screens. The Pathways to Wellness is a statewide refugee behavioral health promotion, which again uses tools such as the RHS 15 to increase provider training and capacity building for these specific populations. It is a collaboration across refugee resettlement agencies and the Refugee Women's Health Clinic to promote greater access to behavioral health services for these refugees. The Refugee Health Promotion Grant in Phoenix also has a collaboration between the RHP Grants and International Rescue Committee and Catholic Charity Services in partnership with the Refugee Women's Health Clinic to address gaps and barriers that refugees experience in accessing and receiving culturally and linguistically appropriate behavioral health services. Rollout and implementation of these projects are facilitated using client-led approach, allowing for client and partner voice in program design while assuring non-duplication of activities among grantees. Here in Maricopa County, we have multiple community programs that are facilitated through cultural health navigators and outreach, but some of these are available in online settings so that they can be accessed by a larger group. Here at Valleywise, we have an Expectant Mothers program, which provides culturally informed health education by the cultural health navigators for refugee women in the third trimester of their pregnancy. They discuss planning for safe childbirth, including how to access hospital services, when to present to the hospital, how to receive transportation to and from the hospital for time of delivery. They receive prenatal education in these classes that increases their knowledge, their self-efficacy, and then follow-up survey has shown higher satisfaction with the birth experience for patients who attended the Expectant Mothers program. An online resource that we have created includes educational videos about the COVID-19 vaccine. There are 11 individual videos that are available on YouTube and available for any clinic to utilize, in which the cultural health navigators and healthcare workers from the Valleywise Refugee Women's Clinic and Pediatric Refugees Clinic explain the COVID-19 vaccine and give quality education on the vaccine itself. These are available in 11 different languages as seen here. We also have a refugee survivors of gender-based violence network, and this includes trauma-informed care, cultural competency, and women's empowerment for these survivors. We also have specific initiatives such as that for healthy Burmese and Bhutanese communities with promoting health literacy through the help for health with multiple community partners, including the ASU and NIH. Additional videos that could be used from any clinic include the videos for Somali women on reproductive and preventive health, and for Congolese patients for messages about gender-based violence in another 6 videos. But how do we use all of these tools and all of this information to advance health equity? The American Medical Association has discussed approaches for advancement of health equity to include embedding equity in the practices, process, and innovation within a healthcare community, the building of alliances and sharing power with the community-based programs, ensuring equity and innovation for marginalized and minoritized people within the community, and to continue to push upstream, working to address all social determinants of health as possible, and to foster truth and reconciliation for racial healing and transformation within the healthcare system. Integrated models of care address the social determinants of health, which then goes to contribute to improving health disparities. Also discussing tackling preventative health measures to reduce the morbidity of emerging chronic diseases. It is important to have research and community engagement to consider the ethical work with vulnerable populations who have survived human rights abuses, and make sure that when we are working with these vulnerable populations, we are doing so with validated instruments with ethnocultural specificity and are working on community capacity building models. Women's empowerment is key to be able to help facilitate women to have their self-efficacy, to make their own medical decisions, and therefore be more engaged in their care, which we have found to lead to better health outcomes. Equitable access is paramount in making this trust, both access to health insurance, transportation, appropriate interpretation, culturally competent providers, and high quality care.
5 minutes.
Here are many of the smiling faces of the Refugee Women's Health Clinic that I am so honored to be working with. So for my conclusions, I hope I have demonstrated that refugees have specific cultural and healthcare needs, and that with using community-based resources and cultural health navigators, we have found we can improve healthcare outcomes with this tailored care. I've also listed multiple resources here in Maricopa County in Phoenix, Arizona, but many of these resources are also available online for those who are joining us from other areas. But trust is key to have the patients involved in their healthcare and showing up so that we can help them achieve their health equity goals. Thank you so much for your attention.
Does anyone have any questions for Dr. Willie? You can put them in the chat or the Q&A. Dr. Willie, there was a question that came through earlier around the use of the assessment tool and the involvement of the community health workers in that with that tool, since they're the trusted partner.
Yes. Yes. So in Valleywise, between all of our different clinics, we have determined what questions are necessary on the initial screening, just so that we can understand our patients and where they're coming from. We assess the country of origin, country of asylum, years in a refugee camp, as well as years in the United States and where else the patient has lived, who their support system is at home, since many of these patients have left their support network in their home country, and then who all they are supporting and what education that they have received. In this way, it helps the healthcare workers understand what type of education we have to use. Am I going to be using illustrations and diagrams to explain a pathologic course, or am I able to use terminology such as that of organs? And so it is very helpful for us. We have some other questions coming into the chat. So one is, what training do the cultural health navigators receive? And how do we recruit, retain, and support them? So they are formally trained in language interpretive services, but that is just one portion of their what they're bringing to the table. These are also they're also individuals who are coming from these cultures. And so we have a process in which the cultural health navigators are grandfathered into our program and then trained on site by the cultural health navigators who are already there. This definitely makes it more difficult when we are introducing new languages to our team, as we keep having new refugees from each society, from new countries. But there are several, the NIRC RIM does have some more further information about what to include in the training for a cultural health navigator. Another question is whether or not we serve a pediatric population. I myself am in the women's refugee clinic, but across the hall is the pediatric clinic. And so the cultural health navigators are present in large number for both clinics at the same time. And we do try to coordinate visits whenever possible, so that an expectant mother may then go over to the pediatric clinic before or after her appointment to then facilitate her children's healthcare appointments as well. We also have a family medicine aspect of our refugee clinic. And so again, we're always trying to work together so that these individuals do not have to come to the hospital too frequently, as that is a barrier to them receiving care.
Well, our time is up. So thank you. We have a lot of great comments here. You did an awesome job in addressing trust and really understanding the dynamics that trust plays within the different cultures. So really appreciate that. Do you have any contact information that you could share with the group after on the slides, or?
I do. I will make sure that my email is available so anyone can reach out for further discussion.
Okay,
Thank you.
thank you. Everybody, we're going to start our next panel presentation at 9:10, so stay tuned. Thank you so much, Dr. Willie. Great keynote.